Okay, here we go. Module 9. We'll be covering the concept of infection and then two of the exemplars. There's exemplar A on cellulitis and exemplar H on urinary tract infection. Basic definitions: infection, invasion of the body tissue by microorganisms. Asymptomatic means they have no evidence of the disease, and when disease is when it produces detectable changes. Communicable, it can be transmitted from one person or animal to another. Direct transmission is through body fluids, and indirect is contaminated objects, etc. Okay, some more terms. Pathogen versus pathogenicity. Pathogen is the organism that causes it. Pathogenicity is its ability to produce the disease. Opportunistic are those causes disease in vulnerable individuals. Opportunistic infections would be like the HIV person that gets pneumocystic pneumonia or something that someone else may not develop, but because they are vulnerable, that the opportunistic infection comes in. Asepsis is absence of disease-causing organisms. Or medical asepsis is clean of most microorganisms. Surgical is free of all microorganisms. So there's times we use aseptic technique. So we try to keep medically aseptic. Surgical asepsis is they are free of all microorganisms. Sepsis is that acute illness where the entire body has an inflammatory response. That is a systemic infection. Okay. Multiple categories. The most bacteria are what most commonly cause infection. Viruses enter living cells to reproduce. Fungi are yeasts and molds. And then we have parasites, protozoa. Usually you'll get from like a food. Helminths, which is your worms. Arthropods, like insects that carry an infection. Colonization. This microorganisms grow and multiply but do not cause disease. They become resident. So you will hear those terms where somebody is colonized. Unfortunately, some people have colonization where they're not having symptoms or the infection of a strep throat, but they're colonized and they can pass it on to somebody else. A lot of people in healthcare will get colonized with MRSA, methicillin-resistant staph, usually in their nares. It's living in there. They don't have symptoms, but unfortunately, without good hand hygiene, can pass it on. Infection was the microorganism invades part of the body that is not able to fight it off, so an infection is produced. It can be local or systemic, acute or chronic. Acute, it usually appears suddenly and for a short period of time, where chronic is developed slowly over a long period of time. Chain of infection, I'm sure you have seen this before. You need a susceptible host. Then there has to be a portal of entry. It has to be able, reservoirs where the bug lives. And in healthcare, it can be living on a surface that is not cleaned well. And so you have this, say, methicillin-resistant staph that is somebody didn't clean it well, so it is sitting on this on the bed rail. So somebody comes in who is very ill, so their immune system is suppressed, and they are now susceptible. They have an incision because they've had surgery. So the skin, our natural first defense, is broken. So there is a portal of entry for that MRSA to enter. Means of transmission. Somebody comes into the room, does not use proper hand hygiene after touching a surface in the room. Then they go and they don't wash their hands and they touch, they're cleaning the wound, the incision, and there's your means of transmission. Okay, that's just to give you an idea. Infections can develop during patients' stay in the hospital. These are hospital-acquired infections, or HAIs, hospital-acquired infections. And then there's also healthcare-associated infections, which is also HAIs. That's where any type of healthcare, multiple healthcare entities other than hospitals, like in a clinic, long-term care, health department, anywhere that is physical therapy, anywhere that's providing health care of some sort. The top three, the most common there, if your hospital or healthcare associated infection, is your urinary tract infections. Then second in there is your surgical sites and pneumonia. If you think of vulnerable, the example I gave you of a vulnerable person because they're ill, suppressed from surgery or whatever, especially if they've had surgery, they have a portal of entry. Pneumonia, they have had, again, surgery, or they're sick and they're splinting, so they're not expanding their lungs completely. The lungs are not expanding. It starts to compress in the lower lobes, and the bacteria starts to produce. Infections associated with delivery of healthcare usually occur after 48 hours of hospitalization. C. diff is another healthcare-associated infection. And just so you're aware, HAIs, or healthcare-associated infections, leads to 90,000 deaths. That's quite a bit. Okay, hands are a common vehicle for spread. So hand hygiene is the number one way to decrease spread of infection. CDC recommends alcohol-based antiseptic rugs before and after patient contact. Yes, you use gloves, but that still does not eliminate the need for hand hygiene. Hand hygiene is the number one way to prevent spread of infection. These are terms just to be familiar with. You will see these terms. I am not specifically giving you questions on this, but these are terms you will start to hear. MRSA is so common, the methicillin-resistant staph. Then we have multi-drug-resistant tuberculosis, penicillin-resistant strep pneumoniae. I remember I was working as a nurse when VRE came out, vancomycin-resistant enterococcus. This is all based on antibiotic overuse. Common sources are having indwelling catheters, being on ventilators, not using proper hand washing, overuse of antibiotics, all are leading to these multiple antibiotic resistant bacteria. Genetic considerations, medical therapies may predispose, like patients with cancer getting radiation, different diagnostic procedures that may have to be invasive, going through our normal barriers, like a cystoscopy. Even though you don't have a needle, it is going into our orifice. Medications can suppress our immune system or lower our white blood count, mess with our normal body's response. Diabetes does increase risk for infection when we get older, especially with chronic diseases. Health promotion, nutrition, hygiene, washing hands, keeping our skin intact, getting the bacteria off our skin, brushing teeth twice a day, part of activities of daily living. Nutrition, proper nutrition, balancing out, getting the proper amount of vitamins, minerals, fluids, proper sleep, getting adequate sleep, and sleep that produces rest, decreasing stress, making sure we have appropriate immunizations. Isolation precautions, I think you covered these in lab. If you haven't, you will. Standard precautions are what we do on everything. Treat everybody as if they're infectious. Using gloves, washing our hands. And then transmission-based airborne droplet contact, depending on the disease process. Diagnostic tests. I do want you to be familiar with what tests do you do when you're looking for an infection. white blood count because you're looking for leukocytosis, which is the increase in white blood cells. You're looking at white blood cell differential, the different types of white blood cells because of increases, again, in fighting infection. You'll look at your differential, your bands, which are your immature white blood cells. When your body's fighting an infection and it's fighting and fighting and it can't keep up, then your immature white blood cells or your bands start to increase, again, with your body trying to fight. Cultures. You're going to culture the wound or the blood, the body fluid, sputum, urine, because you need to find out what bacteria is growing. Don't worry about serology testing, radiologic exams, chest x-ray, abdominal x-ray. We've talked about things with the elimination system, the different type of testing, lumbar puncture, looking in the spinal fluid for like meningitis, ultrasounds. Echocardiogram is an ultrasound of the heart. You can look at the valves for infection. Renal ultrasound, you're looking for changes, scarring, the building up from repetitive urinary tract infections. Urinalysis, checking for things that don't belong in the urine like white blood cells and bacteria and proteins. Stool cultures, again, looking for bacterial growth that should not be present in your stool, or worms or anything like that. Okay, independent interventions against those things that the nurse does that she doesn't need a doctor's or provider's order for. Hand hygiene, basic medical asepsis, cleaning off surfaces, washing hands, not transferring infections. Standard precautions, isolation when appropriate. When you're doing wound care, your sterile field, as sterile as you can be. PPE, personal protective equipment, and decontamination. It is the nurse's responsibility to wear personal protective equipment. Whatever may be splashed or put on you, you're going to protect. So you're wearing your gloves. If there's a potential for splash, you're going to wear a shield. If it's airborne droplet, you're going to wear a mask. If there's a potential to get it on your clothing, you're going to wear a gown. Personal protective equipment appropriate for your situation. And it is the nurse's responsibility to promote psychosocial needs. If a patient is in isolation, remember that. Isolation, promoting psychosocial, because they can suffer from sensory deprivation and a decreased self-esteem. So you want to give some stimulation, you want to interact, not avoid the isolation room. So give them ways to have some stimulation, whether it's TV, music, interaction. Always be affectionate. It's very difficult sometimes in isolation when you have all these barriers on. The patient or client can feel very isolated, so do everything you can to promote some warmth in there. Older adults, normal aging may increase risk of infection, delay healing. It is maybe more difficult to assess or notice infection early because the decreased immune response. So again, I mentioned they might have pneumonia and only have a temperature of 99.5 or 100 versus if somebody younger had pneumonia, they might have 102. Or they'll come in with urinary tract infections and not have a fever, and their only symptom may be that they are confused. That's a common thing. Okay, so exemplar 9A is cellulitis. It's an acute bacterial infection of the dermis into a deeper layer of the skin. Red or lilac, tender, warm edematous. They will be inflamed. They have intense pain and swelling. And these type of things were discussed in the case study that was presented by one of the students. It can be due to trauma or compromised skin barrier. They may have like diabetes and decreased sensation. So not know when they have a little cut in the skin and the bacteria gets in and develops this infection into the dermis. If it's severe infections, they have fever and elevation in the white blood count, which is their leukocytosis. They may have lymph node enlargement, swelling in the area. Very important to teach the patient what they're looking for. Older adults more vulnerable because the skin is thinner, less elastic. Neuropathy, nerve damage, not as active sensation. Reduced physical activity, so they have blood pooling because it's not promoting the lymph system to have return blood flow. Diabetes is a huge risk. Obesity, if they've had cellulitis before, if they have peripheral vascular disease, so their flow is not good. Tinea pedis, which is what we call athlete's foot. It's a yeast fungal infection on the feet and a weakened immune system. All risk factors. So diagnostic tests, like with any infection, you're looking at a CBC. You may see an increase in their white blood cells. You may see a change in their differential. You may have to do check body fluids like blood cultures, sputum cultures, urine culture. If there's weepage at the cellulitis site, you do a wound culture from there. You're doing more of these like blood culture, maybe other fluid culture if they look very, very ill, like they might have a systemic infection, you're looking for sepsis. Know this slide, evidence-based wound management. Keeping the wound moist, pressure irrigation, compression, keeping the wound covered, using antibiotics, teaching the patient to protect that wound, teach them signs of infection. They need to report immediately if there's redness, swelling, drainage. This is on your evidence-based section on page 596. Very important that the patient knows what to report because they're going to be going home and they may have home health doing wound care. They may be going to outpatient physical therapy, but ultimately is the patient and the family that is observing the site. And it is not normal for it to be weeping. It is not normal for them to have a fever. It is not normal to have redness, inflammation, and drainage. It should be getting better, not staying the same and not getting worse. Non-pharmacological, teaching them also to rest, to elevate the area, to decrease the swelling, because the more swelling, the slower the healing and a higher chance of infection. Hand washing, discarding of dirty dressings appropriately. Nurses need to be aware if the family patient is using complementary health practices, whether it's over-the-counter herbs or they're using something else, because sometimes those are effective, sometimes they may interfere with care, so the nurse needs to assess and ask those questions. Assessment, vital signs, especially fever, looking at the affected area for redness, swelling, warmth, looking at the size, measuring it to start with so you know if the size is changing. Frequent assessment, looking for involvement of the lymphatic system. Are the lymph nodes getting enlarged? Are there lymph areas that are tender or swollen? Is the wound drainage starting to drain? Is it bloody? Is it serous? Is it serous sanguinous? Does it have an odor? Does it look pussy? Implementation. Antibiotics. It is very important. Antibiotics are prescribed for a specific length of time for a specific infection. So it's nurses' responsibility to educate that the antibiotics have to be taken for the full course. They are not to be stopped because things are feeling better. Missed doses need to be taken. They may, warm compresses for cellulitis can be comforting, elevating the limb, bed rest because you don't want the infection spreading. Really educating them on importance of compliance and what to look for possible complications, and teaching throughout their treatment to keep them involved and safe. Okay. Last thing in infection module 9 is module 9H on urinary tract infection. It can be bacterial, viral, fungal. It can be in the lower urinary tract infection being urethritis, prostatitis, cystitis. Prostatitis is obviously exactly what they look like, what they sound like. Urethritis is urethra, prostatitis is prostate, cystitis is bladder. Upper pyelonephritis is the most common. That's in your kidney, what they call your renal pelvis. Pyelo is pelvis. I think it's Latin for pelvis. And you think of pelvis like a basin, so your renal pelvis is your basin, and so that's where it's prone to pyelonephritis, and infection spreads up the urethra, bladder, into your kidney. It can be acute or chronic. It can be community-acquired or healthcare associated. It can involve multiple components of the urinary tract. It does not necessarily isolate in one place. Infection can interrupt urinary drainage system. Most commonly acquired UTI infections are caused by E. coli. That's where your perineal care is so important, teaching cleaning front to back. It is very uncommon for men under the age of 50. It is very common in females, especially young females. I think I just covered these terms, didn't realize I had the thing. Cystitis, inflammation of the urinary bladder. Pyelonephritis is when it's in the renal pelvis, or a kidney infection is what we call it. Vesicular lateral reflux, the urine moves from bladder back toward kidney, which you should cover that more when you get into pediatrics, again with your reflux, which is backflow. Hydronephritis is when the urine, accumulation of urine, because it's obstructed. Usually you'll see that with a kidney stone, and the kidney gets very swollen and inflamed because the urine's backed up. Neurogenic bladder, the bladder doesn't squeeze as well for neurogenic damage. For multiple things you will cover throughout your med-surg courses. Etiology, it's the second most common infection in children. It can travel up. 10 to 15% of hospitalized patients that have an indwelling catheter will develop bacteriuria or bacteria in their urine. And don't worry about this slide so much. We're going to keep moving. Catheter-associated urinary tract infections. It's a major healthcare-acquired infection. How do we prevent it? We prevent it through strict guidelines on insertion of catheter, avoiding indwelling catheters, trying to go more to straight in and out caths, providing good perineal hygiene, assessing for bladder urinary retention, as we discussed in our elimination units. Best practice for maintenance, including timely removal, care and maintenance, and hygiene. Okay. Females are highly at risk because the short urethra increases when they're sexually active or changing sexual partners, using diaphragms, spermicides, their personal hygiene, and retaining urine puts them voluntarily waiting to urinate and puts them more at risk for urinary tract infections. It is a good measure to teach to empty bladder before and after sexual intercourse for the female to decrease risk of infection. Males can be more at risk as they get older with bacterial breast prostatitis, which can be from a sexually transmitted infection. Circumcision is protective. The uncircumcised male is more prone to urinary tract infections. Those participating in anal intercourse, these are risk factors for males and UTIs. 40% of urinary tract infections are asymptomatic. If they have symptoms, it's painful urination, frequency, and urgency. That's the most common. Also, foul odor, cloudy or bloody. Suprapubic pain, that's down low, or tenderness, bladder tenderness, that's in the lower area. So if they're just having vague symptoms, you are asking any pain, burning, irritation with urination, frequency, urgency, is there foul odor, is there change in the color of your urine? This is looking for lower urinary tract infection, because if it's not treated, it can ascend up. Into the clinical manifestations here for upper, which is your pyelonephritis, which I explained that being up into the renal pelvis, high fever, chills, abdominal pain, CVA tenderness, which you should have learned the flank pain, CVA tenderness in health assessment, can have persisting vomit, and a lot of times you'll see nausea, decreased appetite, and can lead to dehydration. Diagnostic test, of course, you're checking the urine. You're looking for white blood cells, bacteria, proteins, blood. CBC, looking for an elevation in your white blood count, looking at your differential for changes, and culturing that urine. And if these are recurrent, then you're doing further tests looking for some sort of obstruction or scarring in the urinary tract system or urinary system. Okay. Other tests that can be done if warranted. I'm not going to go into this a lot. You have your renal calculi, which you'll study later, and there's other tests to do, which we'll cover in different med surges, so I'm going to go past this. You can have ureteral stents. Again, this is going to be covered more in later courses, so I just want you to be aware of them, but I'm not going to test you on it or go further in this. You want non-pharmacological, you treat them low sugar drinks to decrease risk of infections. You want to increase their fluids, avoiding or decreasing caffeinated beverages, decreasing alcohol or avoiding alcohol, soft drinks, citrus juices. All these things can be irritating. So these are measures that a nurse can take to decrease healthcare acquired infections or decrease risk of urinary tract infections. Older adults, the most common UTI is common in both community dwelling and facility dwelling older adults. They may not have the classic symptoms. They may just have a fever. They may have a low temperature, actually of 96 or 97. The hugest thing you will see in older adults is behavior change. A lot of times they have absolutely no symptoms. They're just getting confused, which can be difficult if they early have dementia, but they may be more aggressive or lethargic. And the first thing you want to check is for a urinary tract infection. Provide education for teaching risk factors of urinary tract infection and what to do. Decrease use of indwelling urinary catheters. Try to use alternatives such as stray caths if you can, getting them up and mobile, teaching them about bladder control, decreasing caffeine, decreasing sugar drinks, decreasing use of indwelling catheters, teaching perineal care. Here, look over the slide, be aware of these. These are things I was saying, teaching, facilitate effective urinary elimination. So you're monitoring and you're teaching the patient to look for the color, clarity, and odor of their urine. If they have impaired urinary elimination, whether it's stress incontinence or any kind of incontinence or retention, to avoid caffeinated drinks, citrus juices, artificial sweeteners, sugary drinks, and alcoholic beverages. When inserting its straight or indwelling catheter, using strict aseptic technique, and use a closed drainage system. When possible, use intermittent straight cath rather than indwelling. Maintain the closed urinary drainage system using aseptic technique whenever you empty it, providing perineal care regularly and after any defecation. You need to look over the slide, be very familiar with this, and be able to apply this. And that is the end of Module 9.